Wrong site surgery has likely been an issue since surgery itself began. It can occur for a wide variety of reasons, and in a variety of ways. The most common types of wrong site surgery involve a surgeon performing an operation on the wrong patient, the wrong side of the body, such as the widely publicized case in 1995 where a surgeon amputated the wrong leg, and the wrong location but correct side of the body, for example, removing the wrong finger from the correct hand. Or, wrong site surgery can simply be performing the incorrect surgery on the correct patient. Wrong site surgery is relatively rare, with it occurring approximately 1 in every 113,000 procedures performed. Cases where wrong site surgery cause long-lasting or permanent complications are even rarer, making up an estimated 8% of total wrong site surgery cases. There are many reasons that a surgeon can end up performing surgery on the wrong site. Similar patient names can cause confusion on which procedure is to be performed on which patient, especially in cases where both patients are hospitalized for similar reasons. Poor procedures for verification, or lack of any type of verification, can contribute to a higher rate of human error. Unclear markings are also a common source of error. Unclear markings can be as simple as using an X with some operating teams to indicate the side that should be operated on, and the same X indicating the side that should not be operated on with other surgical teams. Also, using the term right to indicate correct can lead to a confusion with right as in the right side of the patient's body. Most cases of wrong site surgery occur when a surgeon is relying too heavily on their memory to verify patient and procedure details.
On a survey conducted in 2008, 8.9% of surgeons reported major medical errors within the past 3 months. Over 70% of these surgeons attributed the error to personal rather than institutional factors such as overnight call, practice setting, method of compensation, and the number of hours worked. The survey noted 3 domains of burnout, which were emotional exhaustion, depersonalization, and personal accomplishment. Using the odds ratio, a 1-point increase in depersonalization was associated with an 11% increase in the likelihood of reporting an error, and a 1-point increase in emotional exhaustion was associated with a 5% increase in the likelihood of error. In 2010, another survey reported that over 15% of practicing surgeons scored consistently with alcohol abuse or dependence. Interestingly, the prevalence of alcohol and substance dependence was 10% higher for females than in males. Using the odds ratio, surgeons who reported a major medical error within the last 3 months reported a higher dependence on alcohol. Surgeons who were burnt out and depressed were also more likely to be dependent on alcohol and substances. Since this is a major issue, hospitals need ways of identifying and helping surgeons who turn to alcohol.
After taking a look at a lot of the malpractice claims, the American Academy of Orthopedic Surgeons created Sign Your Site, and this promotes marking the surgical site. A special aspect of this campaign involves putting a no on the incorrect site. As well, the North American Spine Society helped by adding sign, mark, and x-ray, and this involves making a mark on the site and side of the spine and a checklist which helps with verification. In this slide, you can kind of see the checklist from the American Academy of Orthopedic Surgeons. So it just has basically like it says a checklist, and you just check off each part that you do. So for example, the first part is surgeon involves the patient in confirming the operative site during the marking of the operative site by the surgeon. Copies of the operative permit, informed consent form should state the site and site of surgery. Another part of the checklist is immediate members of the operative team double check each of the following items against the marked site. So they have to check medical records, x-rays, other imaging studies, operating room record, informed consent, the correct equipment, implant devices that are available, and so on and so forth. And then at the bottom of the checklist, it actually requires that you complete everything on it, and the bottom it has the patient name, the physician, the procedures that are performed, the date, and then the signature of the person that's completing the checklist. So in 2003, the Joint Commission, along with the American Academy of Orthopedic Surgeons and other organization leaders, they actually held a summit to discuss the ways to help decrease and eliminate wrong site surgery. So at this summit, there was 3 things that were discussed, and they are as follows. So the increased amount of reported wrong site surgery that are occurring, the effects that wrong site surgery has on healthcare professionals, patients, and their families, as well as healthcare costs in relation to wrong site surgery. The Universal Protocol for Preventing Wrong Site, Wrong Procedure, and Wrong Person Surgery was created from this summit, and it was meant to be used within any places where any invasive procedures were going to be completed. Essentially, this protocol was made to decrease the amount of wrong site surgery cases that occur, and it was made by having a series of steps, which some of these steps includes verification of patients as well as marking the correct site. Now, in order to make it even more efficient, it actually, the protocol set in place the procedure of a physician initialing the site before the patient is sedated. Wrong site surgery is preventable, and that's why the protocol actually was founded on prevention theories that are involved with safety measures that are taken within high-risk industries such as where nuclear weapons are made and for aviation. So basically, once a procedure in the operating room starts, it can't exactly be reversed, and the malfunctioning parts can't just be disconnected from the functioning parts. This universal protocol has 3 essential parts. The first one is preoperative verification process. The second is marking the operative site, and the third is taking a timeout. Now, on July 1st in 2004, the Joint Commission started to have these essential parts in its accreditation process for healthcare organizations. The Association of Perioperative Registered Nurses created a correct site surgery kit, and this was to help healthcare providers with implementing the wrong site surgery protocol. It was endorsed by the American College of Surgeons, the American Society of Anesthesiologists, the American Society for Healthcare Risk Management, the American Hospital Association, and the American Association of Ambulatory Surgery Centers. So as you can see here, this is the correct site surgery kit and what it includes. So there's a pocket reference card which outlines the steps that are necessary to promote patient identification, site marking, and the timeout part. A sample policy template for implementing the Joint Commission Universal Protocol. There's a sample policy checklist template. There's updated statistics from the Joint Commission. There's universal protocol facts for preventing wrong site, wrong procedure, and wrong person surgery. There's also frequently asked questions from the Joint Commission. There's sample videos which demonstrate timeout procedures, as well as the American Academy of Ophthalmology Wrong Site Task Force recommendations, the WHO Surgical Safety Checklist, and WHO Surgical Site Safety Checklist videos. There are plenty of other organizations that have contributed to the prevention and elimination of wrong site surgery by developing tools and policies. So the Veterans Affairs National Center for Patient Center, they created the Ensuring Correct Surgery and Invasive Procedures Directive. So its foundation, it lies on root cause analysis, and it adds 2 steps to the universal protocol. The first step being making sure consent forms are given out and used properly, as well as ensuring 2 people from the surgical team look over the patient's information and radiological images before the surgery is even started. The operating room briefing tool that's used at Johns Hopkins Hospital involves the expansion of the timeout part of the universal protocol by encouraging more communication and dialogues between each healthcare team within the healthcare setting, so between the nursing team, the surgical team, and so on and so forth. The British National Patient Safety Agency introduced a risk management tool, and it created a system of double checking and determining the people who are accountable for each surgical marking site at different stages.
Wrong site surgery is not a result of poor standards of practice, but a result of individuals not following proper procedure. Since this is an easily preventable mistake with serious consequences, it should not be taken lightly, and when something of this nature does occur, it should be dealt with seriously and responsibility should be taken. There are many areas in which simple standards of practice can help to avoid any future wrong site surgery occurrences. Records of every step of the surgery should be delegated to an individual whose entire responsibility is recording the surgery and submitting his or her report. Having all records submitted to a supervisor should ensure proper procedure is followed. Public awareness is another important area for improvement. Any surgical facilities should have signs depicting the World Health Organization's surgical safety checklist and explaining general procedures. In appointments prior to surgery, the entire procedure and proper protocol should be explained in detail, and the surgeon should be confident that the patient is completely aware of what will occur on the day of the surgery. If the patient is aware of the proper procedure, they can ensure that proper procedure is taken and the proper surgery is marked out on their body. Another idea to reduce wrong site surgery occurrence is to set up an anonymous tip line where healthcare practitioners can anonymously inform the authorities if standards are not being met. Combine all of these ideas with harsh punishments for not following proper procedure, and wrong site surgeries will be reduced.
In conclusion, wrong-sided surgeries are still occurring, but the number of reported incidences have increased over the years. It is unlikely that all wrong-sided surgeries will be reported because of the stigmas behind the situation, but as reports become more readily available, it is possible that a shift may occur to reduce or eliminate this phenomenon.
Hi there, sir. Can I have your hand now for a second? Diamante, will you squeeze this arm?
Sure.
We're just going to pop a drip into your hand there. You've checked him in, haven't you?
Yeah, I've done it already.
Yeah, brilliant. And if you can fill in the boxes on the WHO checklist.
Yeah, I'll
as well.
pick them later.
Yeah, that'd be brilliant. Okay, so what you feel now is a sharp scratch, and then we'll just...
Swap, please.
Time out, everybody.
Knife, please.
Can all team members introduce themselves?
Amit, we don't have time for this today. We're running late and we have lots of cases to do.
What's patient's name?
He is Mohammad Bashir, cholecystectomy.
Come on, focus here. Focus.
Sorry.
Mr. Muthi, how much blood loss are you expecting?
None, Amit. Amit, this is a straightforward case. Just stick everything.
Antibiotic prophylaxis?
Huh?
Antibiotic prophylaxis?
No, he hasn't had any. Do you want some, Krishna?
You haven't given any yet?
It's a surgical decision. You haven't told me to give him antibiotics.
We always give it Augmentin, Helgi.
Not always, no.
Kamal, you happy to close?
Yeah, sure.
Mr. Murthy, can we do the sign out, please?
It went well, Amit. No problems. Have you sent for the next patient?
Yeah, he's in the anesthetic room.
But